Hello everyone, I'm Daisuke Kikuchi.
I'm Nobuhiko Ogasawara.
We are from Department of Gastroenterology, Toranomon Hospital, Tokyo, Japan.
On behalf of all co-authors, we appreciate for the acceptance of our original article. We are really honored to be invited to the GIE video interview.
I'd like to discuss the framework of our article entitled Long-Term Outcome of Cervical Lymph Node Metastasis in Superficial Pharyngeal Squamous Cell Carcinoma after endoscopic submucosal dissection with Dr. Kikuchi. Dr. Kikuchi has been engaged in ESD of superficial pharyngeal squamous cell carcinoma (PSCC), as well as other gastrointestinal carcinomas for a long time.
First of all, I'd like to ask you about the history of ESD for PSCC at Toranomon Hospital.
We began to perform ESD for superficial pharyngeal squamous cell carcinoma in 2007, and we have treated more than 600 lesions in over 350 patients for 15 years at Toranomon Hospital. We have continued to make improvement so that we can perform ESD for PSCC safely and efficiently by using various devices and applying a unique method of endoscopic observation.
Thanks. Today, with recent innovations in ESD, superficial PSCC has received increasing attention as a therapeutic target in the gastrointestinal field, as you said. Could you tell me the problems you see in the treatment and follow-up of patients with PSCC?
I think the opportunities that endoscopists encounter PSCC are increasing because PSCC is also often detected as a metaclonus cancer after the treatment of both esophageal and pharyngeal squamous cell culture. The main problem is that there are currently no defined criteria for the application of ESD to superficial PSCC. Although we usually perform ESD in accordance with the treatment of esophageal cancer. One of the serious issues we encounter during follow-up post-ESD is cervical lymph node metastasis. I believe that identifying the clinical pathological predictors of surgical lymph node metastasis can help to provide a basis for the refinement of therapeutic strategies for superficial pharyngeal squamous cell culture.
I'd like to provide a brief overview of the current study.
We evaluated the risk factors of cervical LNM in 331 patients with superficial PSCC without history of CRT for PSCC. Moreover, we investigated the correlation between tumor size and tumor thickness, since tumor size, rather than depth, is the dominant factor in the current TNM classification for PSCC. The median follow-up period was 4.8 years. The cumulative 5-year cervical LNM rate was 6.1%. We identified tumor thickness of over 1,000 micrometers and positive lymphatic invasion as significant independent predictors for cervical LNM. Moreover, one of the novel findings in the current study is that both factors were also revealed to be significantly associated with cervical LNM, even when the cases were limited to 204 cases with subepithelial invasion. From this result, we think that tumor thickness is superior to tumor size in predicting cervical LNM. Although we found positive correlation between tumor thickness and size, there was noticeable variabilities in the values. In fact, we revealed that the tumor thickness was over 1,000 micrometers in 15.9% of PSCCs with tumor size of less than 20 mm, classified as T1, and we think that the current staging classification is inadequate to identify groups at high risk of cervical LNM.
Importantly, none of the patients die from primary superficial PSCC, and all of the patients who received therapeutic cervical dissection for cervical lymph node metastasis survived during the follow-up period. I think that this may be due to surveillance imaging, including CT and cervical ultrasonography, which is routinely performed every 6 months for high-risk patients at our institution. To determine the optimal treatment strategy in advance, I think that establishment of an endoscopic diagnostic algorithm allowing preoperative identification of high-risk cases is desirable in the future. Moreover, identifying high-risk cases can allow a longer interval of imaging surveillance for low-risk cases, which can lead to the development of an efficient surveillance method corresponding to individual cases. In conclusion, we identified tumor thickness and lymphatic invasion as significant predictors of cervical lymph node metastasis during long-term follow-up after initial ESD for superficial PSCC. We believe that these factors should be taken into account to optimize therapeutic strategy for superficial pharyngeal squamous cell carcinoma. Thank you for listening.